I'd like to thank the conference organizers for the opportunity to present today on behalf of my co-authors. Studies have noted that depression is not only common among people with HIV, but is also an important risk factor for non-communicable diseases as people with HIV reach older ages. Estimates from the US have reported a wide range of prevalence of depression among people with HIV, as high as 67% in some cohorts. Recently, studies have investigated depression as a risk factor for NCDs among people with HIV and have shown that people with HIV with comorbid depression are at increased risk of cardiovascular disease, diabetes, and multimorbidity more generally. The hypothesized mechanisms for this association will be shown on this slide. Regardless of HIV infection, depression can impact biologic pathways and health behaviors that underlie development of non-communicable diseases. The bidirectional association of HIV and depression may further accelerate these pathways and lead to even higher risk. However, recent work focusing on community and structural determinants of health remind us that the context in which people develop and live with HIV and depression are also critical to consider. And these social determinants of health may further impact pathways leading to chronic non-communicable diseases and underlie persistent health disparities in our community. One community level measure in particular of interest to our group is community mental distress. Community mental distress is gathered as part of the CDC-led annual national telephone survey, the Behavioral Risk Factor Surveillance Survey. The BRFIS collects county-level measures of health-related risk behaviors, chronic health conditions, and use of preventive health services. The community mental distress is from the BRFIS question asked to participants, now thinking about your mental health, which includes stress, depression, and problems with emotion. How many days during the past 30 days was your mental health not good? And the number reported is averaged across respondents from the county. Community mental distress has been shown in the literature to correlate with other key measures of social determinants of health, as well as environmental exposures that could impact NCD risk and other health behaviors. Our group has shown that among people with HIV, those living in communities with higher measures of community mental distress were less likely to link to HIV care. With that background, our group sought to address the question, independent of individual depression, is community mental distress associated with NCD risk in people with HIV? We performed a cross-sectional analysis of adults with HIV receiving care at the Vanderbilt Comprehensive Care Clinic in Nashville, Tennessee from 2009 to 2019. We used address county information from the baseline time point or time of clinic entry after 2009 to collect BRFIS mental health distress measurements closest to that date for all patients. Our primary outcome was the number of NCDs diagnosed before or within 6 months of clinic entry, and the NCDs are listed on the slide as well as covariates of interest. Overall, our analysis included 4,798 patients, and while nearly a quarter of all patients resided in Davidson County, where Nashville is located, patients came from across the state of Tennessee and from all parts of Kentucky and Alabama. To tell you more about the patients included in our analysis, the median age of all patients was 40 years and 78% were cisgender men. 40% were non-Hispanic Black and 50% were non-Hispanic white race. Of the 10% which were neither, the majority were of Latinx ethnicity. Overall, 28% of all patients had a baseline diagnosis of depression. 57% of all patients had no NCDs at baseline. 24% had one NCD, and 20% had 2 or more NCDs at baseline. For all, the median BRFIS mental distress index was 3.0 days, and this map shows the corresponding mental distress indices for the counties from which our patients came from. Of patients with and without depression, the prevalence of NCDs was generally similar. 24 to 34% had hyperlipidemia at baseline, 27 to 33% had hypertension. These were the 2 most common NCDs we observed. The other NCDs occurred at lower prevalence rates, all less than 10% in people with and without depression. We first examined the association of individual depression with community mental distress using multivariable logistic regression, adjusting for the covariates listed on the slide. While higher measures of community mental distress positively correlated with individual risk of depression, the association was not statistically significant. This graph shows the odds of depression on the y-axis relative to the average mental distress value of 2.9. And you can see that as mental distress index rises on the x-axis, the odds of depression slightly increases, though the wide confidence interval spans 1 at all time points. Thus, in our population, individuals from counties with higher community mental distress were not significantly more likely to carry a clinical diagnosis of depression. Next, we examined whether community mental distress index was associated with number of non-communicable disease comorbidities using multivariable proportional odds models, which included the listed covariates. Consistent with other studies, we found that after adjusting for pertinent confounders, prevalent depression was associated with a 21% increased odds of higher NCD comorbidity burden. When we looked at Burkitt's community mental distress, we again saw a trend towards a positive correlation whereby higher community mental distress was associated with higher NCD burden. However, this association did not quite meet statistical significance after adjusting for the individual level risk factors. Lastly, as part of a planned analysis to address questions of health disparities, we repeated the multivariable model with the inclusion of an interaction term for race, ethnicity, and community mental distress. The interaction term was statistically significant, indicating that the relationship between community mental distress and NCD burden was modified by race, ethnicity. Interestingly, we observed a null association between community mental distress and NCD burden for non-Hispanic Black individuals and a positive association for non-Hispanic white individuals, suggesting higher community mental distress was associated with an increased individual NCD burden. For the other race ethnicity group, we observed an inverse association between community mental distress and NCD burden, though this result included a very wide confidence interval spanning the null. A couple of words of caution with regards to our study. First, this study was from a single clinic site in the U.S. Southeast, and results may not be generalizable to other settings. Second, our analysis was limited by the fact that Burkitt's mental distress is only available at a county level, and thus we cannot account for intra-county or neighborhood heterogeneity in mental health or other social determinants of health. Additionally, while patients came from a diversity of counties, a quarter came from only one county, reducing the variation in Burkitt's measures in our population and thus our power to detect differences. Finally, this analysis was cross-sectional and thus only examines association, not causality. Further longitudinal studies are needed to examine the relationship of the timing of exposure to community mental distress or other social determinants of health and long-term health outcomes in adults with HIV. With those limitations acknowledged, our study would still offer some important lessons. First, and consistent with other studies, even after adjusting for confounders, depression was significantly associated with higher NCD burden in our population. Second, we found that while positively correlated, the area level measure of community mental distress was not statistically associated with NCD burden among people with HIV. It could be the case that individual risk factors such as age or depression were so strongly associated with risk in our population that no association with area level measures were seen in the multivariable models. Additionally, we observed differences in the relationship between community mental distress and NCD burden by race ethnicity, suggesting heterogeneity in the impact and role of social determinants of health across communities for this outcome. Lastly, our results highlight the need for ongoing work to identify the most important measures of social determinants of health and health disparities, which impact NCD risk and long-term outcomes of adults with HIV. I'd like to thank my co-authors and collaborators at the Vanderbilt Comprehensive Care Clinic and the Tennessee CFAR. We recognize our funders and welcome comments and questions.